Hello, my name is Dr. Shuchi Rodgers, and I'm a clinical associate professor of radiology at Thomas Jefferson University. And today I will be speaking about acute liver failure. These are my disclosures. I'm a book author for Elsevier, and several images in my talk come from an article that I recently published with Dr. Mindy Haro. I'd also like to acknowledge Dr. Mindy Haro for her help with this talk. So I wanted to start by showing some select images from a patient who presented with acute liver failure. Here's an ultrasound image and a correlative CT scan. And I show this to ask if any of you have seen these kinds of images. Have you wondered, why does the liver look like this? And, what should I say? And if you answered yes, then pay attention to this talk, and I hope to be able to give you some insight into this disease. Learning objectives for my talk will be, I will define acute liver failure, list various causes for acute liver failure, explain the varied imaging appearance and the role of imaging in evaluating the ALF patient, and also list some of the criteria that OPTN has for liver transplant eligibility. So acute liver failure is also known as fulminant liver failure. The definition is a patient without pre-existing liver disease who presents with elevated liver function tests, jaundice, rapid onset encephalopathy, and coagulopathy. It is extremely rare, with approximately 2,000 cases per year in the United States and an annual incidence of less than 5 cases per million population. And because it is so rare, the disease is very difficult to study in depth, with very few controlled therapy trials having been performed. Now I'm going to talk about some of the common etiologies for acute liver failure, and the most common etiology in North America is acetaminophen. Other drugs and toxins can also cause acute liver failure. Viral infection and hepatitis, such as viral hepatitis A, B, and E, are some of the main causes outside of the US and in some third world countries. Other etiologies include acute ischemic injury, metabolic diseases, and then miscellaneous causes including malignancy, autoimmune disease, trauma, Budd-Chiari, and transplant graft dysfunction. The problem with ALF is that it can progress rapidly to multi-organ system failure involving all different organs in the body. It can result in acute respiratory failure, muscle catabolism, pancreatitis, sepsis and other infections, adrenal insufficiency, hepatorenal failure or portal hypertension, hemorrhage, neurologic problems including brain edema or hepatic encephalopathy, in addition to cardiac dysfunction or hypotension. Acute liver failure had a very high mortality, approaching 80%, before the era of liver transplantation. But now the mortality has decreased to approximately 33% due to a combination of improvement in ICU supportive care, in addition to liver transplantation. And the latter is performed in approximately 25% of ALF patients. Now, there's no universally accepted classification for acute liver failure, but it has been common to subdivide it into 3 clinical subtypes, which I will discuss later in my talk. Regarding liver transplantation, once the decision has been made to list a patient for transplant, there really is only a short window to perform the transplant, because prolongation of medical therapy may make transplantation impossible due to overwhelming sepsis and multi-organ failure. This is the King's College criteria for liver transplantation. It is the most widely used model based on clinical scoring that tries to balance the risk of organ transplantation with the possibility that medical support and advances in ICU therapy can result in long-term survival. So the most important predictive factors for survival include patient age, the cause of ALF, and the degree of encephalopathy. Now, patients who develop ALF as a result of acetaminophen tend to do better. The OPTN policies effective July 2021 regarding patients who are eligible for adult status 1A for receiving a liver transplant are listed here. So this is defined as a patient who has a life expectancy without a liver transplant of less than 7 days and has at least one of the following conditions: fulminant liver failure. And they define it as an onset of hepatic encephalopathy within 56 days of the first signs of symptoms of liver disease. And in addition, the candidate must not have a pre-existing diagnosis of liver disease, must be in the ICU, and then also must meet at least one of the following conditions: be ventilator dependent, be on dialysis, and have an elevated INR greater than 2.0. Now, these are other patients who would meet criteria for adult status 1A and hepatic primary non-function of a transplanted liver, and these are other conditions. So what does the American Association for the Study of Liver Diseases, or the AASLD, have to say about acute liver failure? They published a position paper on ALF, and they have said that clinical trials and research is impossible because of the rarity of the disease, and much of the management is really based on clinical experience. So the paper discusses the etiologies and diagnosis, therapies and intensive care management, prognosis and transplantation, but there is no specific imaging recommendation. And rather, what they have said is that, as a caution to hepatologists, imaging, when it has suggested cirrhosis, this is often an overcall by radiology because a regenerating massively necrotic liver will give the same nodular profile as cirrhosis. And so the AASLD actually recommends that the hepatologist obtain prompt blood tests to evaluate viral hepatitis serologies, autoimmune serologies, bilirubin, etc., obtain autoantibodies. And then they also say to have a low threshold for biopsy in patients with indeterminate ALF. Now, autoimmune hepatitis may be the largest category of indeterminate cases of ALF after unrecognized acetaminophen poisoning. So ALF subcategories are based on the interval from jaundice to encephalopathy. So a patient is assigned a specific subtype. So hyperacute is if the patient has had these symptoms for the encephalopathy appear less than a week. And this is most often going to be the acute acetaminophen poisoning patient. Acute is when the encephalopathy occurs between 7 and 21 days, and subacute is greater than 21 days and less than 26 weeks. Now, the AASLD has said that terms signifying the length of illness, such as hyperacute, acute, and subacute, are popular, but they're not particularly helpful because they do not have a prognostic significance distinct from the cause of illness. I think that radiologists, we may tend to use it a little bit more often, only in that acute and subacute acute liver failure, those are the patients who more often can mimic cirrhosis on imaging. So the role of imaging is really not in the clinical diagnosis of ALF, because the hepatologists have ordered their labs and they're looking at the patient's clinical status. But imaging is helpful in evaluating the patient and determining the potential for liver transplantation, and in particular, determining if there's any pre-existing liver disease or cirrhosis. Because, the differential diagnosis is an acute decompensation of cirrhosis. Imaging also tells the clinicians the status of the hepatic vasculature, and most importantly, is there a treatable cause or a specific etiology of ALF that needs to be addressed. Now, many times these patients are extremely sick, and ultrasound is considered a mainstay of imaging because it can be performed portably and at the bedside, and it avoids any nephrotoxic effects that can ensue following administration of iodinated contrast. Ultrasound can look at the status of the hepatic vasculature and the flow direction, assess kidneys, and then monitor for the development of ascites and other signs of portal hypertension. So now I wanted to focus on showing some common imaging findings, but I will say that the most common imaging finding, especially if a patient presents in the hyperacute phase, is a normal appearing liver. But a thick wall contracted gallbladder, is a very common finding, and this is a patient, an ultrasound image showing you a contracted thick wall gallbladder with a little bit of pericholecystic fluid. Here's another patient who has a thick-walled small gallbladder, both on CT and correlative ultrasound. Now, these gallbladders are small because the livers are not making bile. This is a different patient who you can see the yellow arrows pointing to echogenic portal triads, and that contrasts with the hepatic vein, which is pointed to by the blue arrow. You can see the difference, and the echogenic portal triads is a result of periportal tracking and edema. Now, this is a CT scan on a patient who presented with hyperacute ALF from acetaminophen overdose. And you can see on this non-contrast CT how hypodense the liver is in comparison to the spleen. And now this is a hypodense liver from diffuse liver necrosis, not from steatosis. Here's a different patient. Oh, no, sorry, this is the same patient who had more inferiorly. You can see the contracted thick wall gallbladder, both on CT and on ultrasound. This is a patient who had drug-induced liver disease, and you could see this non-uniform echogenic appearance of this liver on ultrasound, and you can see on the last image on the right, these echogenic portal triads. You can see that the liver surface is smooth, there is no ascites. Here is the correlative CT scan, and you can see this very varied heterogeneous enhancement of the liver. Typically the hypodense, non-enhancing areas in the liver correspond to areas of necrosis, and the enhancing areas correspond to viable liver. Now, this patient was managed medically, and then over time you can see the development of signs of portal hypertension and liver collapse. You can see at 11 days the patients developed ascites, and you can see that the liver is starting to shrink. We have these echogenic nodular areas starting to get more of a lobulated nodular liver contour, more posteriorly in the back of the right lobe of the liver. And then at 28 days, you can see, more overt changes of liver collapse, and you can see the ascites. And then this patient was followed again over time, and you can see at 44 days, this contrast-enhanced CT is showing you a nodular liver contour, small volume ascites, a little bit of an enlarged caudate lobe. And then finally at 5 years, this contrast-enhanced MRI showing you these regenerating nodules with intervening fibrosis, nodular liver contour. So this patient was managed medically, never received a liver transplant, but now the hepatologists have kind of enrolled him into an HCC screening program. So he's followed radiographically every 6 months. This is a different patient who had ALF from an unknown etiology, possibly a dietary supplement. And this is her liver ultrasound at presentation. You can see this kind of heterogeneous appearance of the liver with echogenic and then hypoechoic areas, no ascites. We see a smooth liver surface. And then 7 days later, look at this marked change in the liver. You can see how shrunken it is. It has a little bit of an irregular contour. We have ascites and pleural effusion. The color Doppler image is showing a patent paraumbilical vein. So definitely stigmata of portal hypertension. So this patient went on to get a liver transplant, and at histology, the patient had massive necrosis of the right lobe with small islands of normal liver. So here's a magnified histology slide, and the arrows pointing to this island of normal liver. Now, this is a very interesting case. This is a patient who had ALF, and it was unknown if it was from autoimmune hepatitis or possibly drug-induced liver disease or DILI. And these two ultrasound images are showing kind of a smooth, rounded area anteriorly with more homogeneous echotexture, but then posteriorly you have more atrophic shrunken right lobe with echogenic areas alternating with hypoechoic areas. And, Dr. Mindy Haro and I were, debating this case at length, especially after this patient got a multi-phase CT scan, trying to determine, which part of the liver was normal, which part was abnormal, why is it enhancing so bizarrely? So if you look here at the anterior part of the right lobe and the medial segment of the left lobe, you can see that it's bulging, but not enhancing on the arterial phase or portal venous phase or late phase. And on the ultrasound, it was corresponding to this more echogenic area. And we knew based on previous imaging that we had thought that the echogenic areas represented islands of, normal liver or regenerating liver. And then the posterior right lobe of the liver was more shrunken and atrophic, kind of had collapsed and was enhancing more than the anterior part of the right lobe. And you can see here's the, anterior, this part that's enhancing more, but on ultrasound, it was hypoechoic and had shown signs of atrophy. So we were really puzzled. Also note this patient now has, ascites and pleural effusion. This patient was showing the typical Doppler appearance of developing portal hypertension with low portal vein velocity and increased hepatic arterial flow. The patient went on to get an orthotopic liver transplant, and there were no tumors or nodules at histology. But you can see this is a gross specimen picture showing you that atrophic right lobe of the liver, which was markedly abnormal and represented collapsed liver, and then this more bulging area that was greenish yellow and then corresponded to this echogenic area on ultrasound. This represented a large area of cholestasis. And so that explained the, very unusual and complicated, confusing imaging appearance of this patient. So here, these are histology slides showing you islands of normal liver. Then we have the purple arrows are showing areas of collapsed liver. And then this last slide is showing you this kind of lattice-like area of liver collapse, so, with central areas of more normal liver. And this was all bridging necrosis. There was no fibrosis, which is distinct then from a definition of cirrhosis. Cirrhosis is where you have regenerating nodules and intervening fibrosis. So I just wanted to make a few comments now about acute, subacute ALF. And with this disease entity, really, we're seeing a little bit more non-uniformity of the hepatic necrosis. Remember, the histology will be nodular liver surface due to regenerating nodules and intervening necrosis. It can mimic cirrhosis on imaging. Remember, histology of cirrhosis is regenerating nodules and intervening fibrosis. And as a matter of fact, a retrospective review of 47 patients with ALF showed the nodular liver surface in 23% of patients, and then ascites in a large percentage of patients, and also stigmata of portal hypertension, including splenomegaly, collateral vessels, and reversal of flow in the portal vein. Other specific etiologies of ALF constitute a small subset of ALF cases, and this refers to the non-toxic, non-infectious etiology. And here, imaging is critical to identify any specific treatments or clinical options for the patient. So, some of the cases that I'll show, are Budd-Chiari, malignancy, and then also massive trauma falls into this category, as well as liver transplantation, particularly primary non-function. So here's a 47-year-old female with acute liver failure who On ultrasound, you can see echogenic thrombus within the middle and right hepatic veins. The color Doppler is showing no normal hepatic veins, but this rather bizarre, intrahepatic venous collaterals. Here's a contrast-enhanced CT showing hypodense thrombus within the hepatic veins, and then you have the enlarged caudate lobe, that flip-flop pattern of enhancement, and you have ascites. So this patient was able to undergo TIPS placement, and the angiographic image here is showing you, lack of normal hepatic veins. And here you can see, here's some thrombus, actually some thrombus also within the portal vein here, but they were able to salvage the patient and she did well. This is another patient who presented with Budd-Chiari. However, this diagnosis was delayed. The imaging findings were missed at the initial ultrasound, but this is showing you here echogenic, almost isoechoic thrombus within the hepatic vein with minimal flow in the hepatic vein. You can see here's a middle hepatic vein showing you that thrombus, and we see thick wall gallbladder and ascites. And here, this is the contrast-enhanced CT showing the 3 hepatic veins without any flow, and here's a patent IVC. And here's the caudate lobe showing you kind of that bizarre type of enhancement and caudate enlargement. This is a patient who presented with ALF, and her liver is very heterogeneous with hypoechoic areas scattered throughout, particularly in the periphery. The liver is enlarged, and she has ascites. Now, this patient had a liver biopsy, and this turned out to be metastatic adenocarcinoma. This is a patient who presented with ALF and has a kind of coarse, hypoechoic, appearing liver with nodular contour on CT. This unenhanced CT, you can see the liver is enlarged and has this almost cirrhotic type appearance. This is a PET scan, and it shows marked uptake diffusely throughout the liver. This was pseudocirrhosis from metastatic melanoma. This is a patient who had an orthotopic liver transplant, and initial spectral Doppler of the hepatic artery was normal with a normal resistive index of 0.69. But on postoperative day number 3, the patient's clinical status markedly deteriorated. You can see the resistive index is now close to 1, and the AST was greater than 3,000, and the patient's INR was greater than 2.5 with the low pH. And this represents primary non-function of a transplanted liver. Within 7 days of transplant, this patient had to go emergent retransplant of the liver. Other pitfalls and issues to consider. One of the main problems can be how to differentiate ALF from acute on chronic liver failure. And there isn't that much literature on this topic. Essentially, the diagnosis is often made clinically, and it's really important because it can affect a patient's liver transplant priority. Another issue is acute hepatitis. Oftentimes the imaging appearance can be very similar with ALF, but the entities are easily differentiated based on the absence of encephalopathy and the lower degree of liver enzyme abnormality in patients with acute hepatitis. Autoimmune hepatitis deserves mention because this is an etiology of ALF that actually likely accounts for a substantial percentage of the indeterminate cases. It is often idiopathic or cryptic, but a specific inciting event occurred in approximately 50% of patients in one series, and the inciting events were drugs or acute viral infections. This is often the clinical criteria include serum globulin concentration, absence of hepatitis viral markers, and the presence of autoantibodies. And at histology, there'll often be lymphoid follicles, plasma cell infiltrates, and central perivenulitis. These patients can do remarkably well with corticosteroid treatment, and on imaging, there's no characteristic appearance. So this is a patient who had ALF secondary to autoimmune hepatitis. She had a history of lupus and elevated liver function tests. Here, the liver is echogenic and enlarged, especially when the liver echogenicity is compared to the spleen. And the patient had ascites and a thick-walled gallbladder. This patient underwent steroid therapy, and imaging 3 years later showed normalization of the liver appearance, resolution of the ascites, and clinically, her liver function tests were normal. So, in summary, regarding the ALF subcategories, which are based on the time interval from jaundice to encephalopathy, so the hyperacute is when that time interval is less than a week. Imaging is most often normal, but you can see gallbladder wall thickening and echogenic portal triads, and your acute acetaminophen overdoses will likely fall into this category. Here you have the acute to subacute is greater than 1 week, but less than 26 weeks. The imaging will be more non-uniform. You can get more of that bizarre pattern of heterogeneous echogenicity on ultrasound and different liver densities on CT. And then you can start to mimic cirrhosis with this lobulated liver contour and develop portal hypertension. Chronic is something, much later on in the disease course, particularly if those patients are managed medically. And these patients will have a nodular liver surface mimicking cirrhosis, smaller liver volume, and also may have ascites or portal hypertension. Yeah, so it's these categories here where it can be difficult to distinguish from cirrhosis. So now, in summary, ALF is a rare disease, but you may encounter it in imaging. Basically, the job of the radiologist is there a treatable etiology for ALF, such as Budd-Chiari, or is there a chance that there could be metastatic disease? It is easiest to use imaging in the hyperacute phase to differentiate ALF from chronic liver disease. And in the clinical setting of acute to subacute ALF, it may be impossible to distinguish cirrhosis from massive necrosis, particularly if these patients did not get imaging very, very early on in their disease. Hepatologists know to view the nodular liver contour indicating cirrhosis with caution in the setting of ALF. Thank you so much for your attention.